Hello, welcome, Brad. How are you?
I'm good. How are you?
I'm doing great. It's exciting to see participants flowing in every time webinar goes live.
It is exciting, isn't it?
Mhm.
I've got a presentation for us to do on shared screen when you're ready.
We are ready whenever you're ready.
Okay, how do we do this? We share my screen.
Yes.
Okay, share. How do I? That's what I want. I was worried that maybe I'd have the time wrong.
No. You are well all on time.
Oh, good. So I'm guided by you in terms of how we want to proceed, and you'll tell me when we can start, and we'll go from there.
Yeah, we're more than ready to wait for you to start. And participants are still flowing in. So while waiting for participants to settle down, Brad, would you like to share more about yourself with the public as well as a little overview? And I'm going to share with everyone today's presentation. We are going to do a bit of case study with Dr. Brad Beira. And also, we're going to open up the floor in terms of unmuting everyone so that we can be more engaged on a communicative engaging communication with each other. All right, so I will be cueing everyone when I'm going to open up the mic to the floor. All right, so the floor is yours, Brad.
All right. Well, thank you, Ariane, and thank you, Keynotion, for today. My name is, as everyone can see, is Brad Beira. I'm new to healthcare. I've only been involved since 1989 and in clinical practice since 1995. So I'm still figuring it out. This presentation is on telehealth and on the transformation of the practice of medicine. I've tried to divide it into two pieces, and I'd be very interested to get your feedback, both in terms of your hands up and in terms of questions that you've got, because the idea of the presentation and how it would flow is to just take us gently into what is the practice of telehealth and telemedicine. What are some of the regulations and guidelines and standards that are informing us and challenging us in terms of this? What are the general opinions towards digital health? And I'll define digital health both in the EU and in the US, and that's dominantly where I've taken the data from. I'll share with you some of my practical experience over 20 years of doing quality health improvement, both, well, largely everywhere except South America, where I've never had the privilege of being. My background academically is I started in practice. I have a master's in technology, some postgraduates in sports. I did a health systems qualification through the University of Public, through School of Public Health, University of California, Berkeley. I then went on to do my law degrees, and I did my master's in law in personal data and health data as it relates to the GDPR. And so that's me by introduction. I hope no one's bored. It's a little difficult speaking to everyone because I can't see you, I can't hear you, and I don't know what your expectations are. So I'm going to rely on you to give me that. The idea will be to start with what I call theory. I call it theory because it doesn't work in practice. We will talk about the theory of consumption of digital records and the use of electronic medical records and patient engagement. And then after that, we'll talk about the practice of, I was with a colleague yesterday who I practiced in alignment with for nearly 25 years. And I said to him, so how are you running your practice? How are you doing with the digital record keeping? And he says, no, I still use pen and paper. And you're going to have to take the pen out of my cold dead fingers because I'm going to keep doing narratives using my folio script. So the theory is everyone adopts it, the practice is less so. So with that in mind and the introduction area behind me, if you're happy, I will continue from there. So I bring this up because in the debate on digital health and telemedicine and e-health, electronic health and m-health being mobile health, there is now an increasing debate to define what is medicine and what is health. And is medicine a subsection of health, or is health a subsection of medicine? So years back, I recall the WHO in the Alma Ata Declaration wrote that health is a state of complete physical, mental, and social well-being, not merely an absence of disease or infirmity. And that creates quite a big debate, because if you are like me, above 50, and you have some degree of comorbidity. In my case, I have a bilateral hip dysplasia, and as a marathon and ultramarathon runner, I needed surgery to remove the can deformity, reshape the angle of the neck of my femur, and allow me to never run again, which I still run. But that doesn't mean I have complete physical well-being. So the aspiration towards what the crossover of clinical optimization versus regulation says, or statement says, are quite different. And so then the question is, well, what do we measure achieving or aspiring towards the state of physical, mental, and social well-being to be? Do we use value-based care, which is payment for quality outcomes which are defined? And I say that because I am the chair of two organizations. One is an organization in South Africa called Safe Surgery SA, where we try and collect perioperative data to understand from everyone around the experience, including the patient, how the best outcomes might look using different construction. And then person-centric interoperable care. And when we start looking at person-centric interoperable care, there's the 3 Ps. There's the patient, there's the practitioner, and there's the payer. And each one has a different view on what they regard digital care to be. So currently, and we can talk a little bit about this if we want to at different stages, but in COVID situations like the one we're in now, where in certain countries you can't go and see your general practitioner or your primary health clinician. So then the issue of telemedicine, which is you having a consultation with a patient with another physician or clinician in a remote space, versus telehealth, where your patient is in a remote state and you're consulting to them. How do you get compensated and remunerated? Now, we'll talk later about one of the countries where they're actually incentivizing the clinicians with an extra 10% of reimbursement if they use a telemedicine consult or a telehealth consult versus if they do a face-to-face consult, to try and improve access in remote areas. So that's the big debate about medicine and health as it currently sits. I use this image that you can see on the right-hand side of your screen, and I use the form transformative technology there because I had the privilege of working with a group called Mudiro, which is a Swiss-based non-profit organization where they fly volunteer clinicians to Namibia and then drive 4 to 8 hours into northern Namibia, into these very, very rural areas. And in these very remote and rural areas, there is no technology. There's no technology because there's no bandwidth, and because there's no bandwidth and because there's no technology, how do you do a diagnostic ultrasound? And so the picture that you see there is a smartphone using a remote dongle doing what we would only have dreamed about doing 2 or 3 years ago, using technology to enable us to where we want to go. So we live in changing times, and I usually have a note on the top of the slide that says to remind me to talk about a neurosurgeon colleague who I work with. Let's call him RM because those are the initials of his name, but he's in his 70s now. And he was frustrated 2-3 years back. We were doing some, I'm a medical legal consultant. So a lot of my time is spent looking at access to care and the legal implications of care. And Roger said to me, he said, I'm so frustrated. Why if we've got all of these smart technologies, do we still need to rely on a stethoscope that uses air transmission from a diaphragm into my ears, which, whilst good, are not as good as they ever used to be? And so why did the stethoscope get formed? Well, it was formed in, I'm told, and you may correct me, out of a French physician's reluctance to put their ear onto the chest of the patient. So they used a rolled up form in order to do that, which then became amplified. So we move in changing times. And in those changing times, specifically in terms of our ability to reach diagnostic opinion, we've got smart machines, and we've got artificial intelligence, and we've got deep machine learning. Really, what does that mean? It means you've got these abilities to take huge amounts of information, have a computer or a multitude of computers aggregate that information, and then come out with a diagnostic opinion. Like when back in the day, back in the 80s or the 90s, you had to make that decision yourself. When I did my first master's on intervertebral disc lesions and pain down the leg, if I wanted an article, I'd go to the back of my reference article, I would take out the article, I would write it down, and I would then send it. So I see there's a question, can I tell you which countries are those using and remunerating 10% or anything for using telemedicine? The answer is yes, I'll tell you, and I will share that with you when I talk about Portugal, because they're one of the countries that's doing that. So thank you for that question, and I'll keep answering them as we go. So short answer as we go back to this is, I would wait 3 weeks for the research article to come back. Now, if I want to know something, I'll type it in, and in real time, I can get a variety of different case studies, peer-reviewed analyses that give me both a diagnostic opportunity, because I can get a lot more information, but also diagnostic liability, because often a patient will come and they'll say, I feel this, and I've been online, and I've diagnosed this, and I want this treatment in this way. Part A. And part B is the flow of information coming in is so great that it's sometimes difficult to compete with someone like AliceCore that detects cardiac arrhythmias, or somebody a diagnostic triage like Helix that actively listens, also displays degrees of empathy or perceived empathy, what they're now calling artificial empathy, in terms of artificial intelligence. So there's a lot going on that's affecting our practices. Now, I don't know how many of you, and I can't see because you can't tell me, how many of you have been in practice in 10 or more years. But I know that when I started, I had a mercury sphygmomanometer to do my blood pressures with. Then I got a EVAN patient monitoring unit a couple of years back that would run a tracer for me, do the pulse, do the BP, do the SpO2, and record all of that in a digital fashion that could push to my electronic medical record. Last week, while doing some work on COVID readiness, I was asked, well, what do you think about using mobile pulse oximeters as a mechanism of showing that there's a risk in a patient who suspects that they've got shortness of breath that's COVID related? I said, well, what range do we look at? Do we look at a SpO2 below 90%, 80%, 70%, 60%? How do we know what comorbidity is attached to that? And so that's why I said these are changing times for us, because information has materially changed the way that we do practice. It hasn't changed the way we do practice because we still need to have a conversation with the patient. Preferably, we still need to see the patient. But I've worked in a hospital. I was a hospital risk manager for many years. And I've worked in a hospital where they send a digital tracer to a third-party facility who then analyzes that, did a diagnostic opinion on whether the SPO, the PQRS waves had any degrees of interval delay to them, and whether this person was at risk of a current or future MI. So there's a lot of changes that have happened. So without belaboring that more, I'm going to keep watching. Are people having difficulty with the sound? Please let us know. I'm speaking loudly, and on my side, the feedback seems to be good. So we go on, if I can move the slide. And so I wanted to talk about this because I was amazed when I did research into GDPR. And we say, well, the GDPR is here since 2018. The reality is the general data protection rules go back to the 1980s. The first rules on data protection were from 1984, modified in 1996. And our journey through, and I say our, in this case, the European Union journey specifically, and if anyone's broader than that, we'll talk about that too, actually began in 1950 with the publication of the Universal Declaration of Fundamental Human Rights that says the information about yourself, what we now under GDPR call special data, being biometric, genetic, and health data, is largely protected under your privacy. Now that's slightly different, and we'll start at the bottom and work our way up, because in HIPAA, which is the Health Insurance Portability related rules, the question is, how does the clinician make the patient's data available to the patient? And those initial rules came out in 1996. GDPR was modified, and the revised GDPR came out in 2018. PIDA is the Canadian rules. The California Consumer Privacy Act, which came out in 2019, was the same kind of sentiment, describing and in some ways prescribing what the rights of the individual are, both to the access to their data, but also to the rights to have their data forgotten when they don't want it done anymore. Now that puts a challenge for us, because as a clinician, your data, whilst belonging to you, actually belongs to the patient. So now the question is, how do you preserve that data once you've recorded it? How do you make sure that it's thorough? How do you manage it in terms of all of the content that needs to be included in it? And then how do you make sure that patients have access to it? So there's that pillar in terms of telemedicine. The second thing that goes with that, and I don't know how many of you have smartwatches or smart devices. When I started running, which was way back in the 90s, in the early parts of my running, I had a Garmin that was about 2 inches by 2 inches. And that was what I tracked my running with. Nowadays, you've got a multitude of different devices, including your smartphone, that can track and trace you down to within 5 feet of where you are. But in doing that, you'll see that I've spoken about the continuous design guidelines. And I put these in so that those of you that are bored or can't sleep or aren't seeing patients or like to read can refer to these. So these are the design guidelines that speak to what is called FHIR, Fast Healthcare Interoperability Resources. Basically what that speaks to is then what devices can connect with each other that record personal data. And how do those devices that record your data speak to programs that integrate that data? And then how does that speak into a health information system? And then how does that help you? And so when we start looking at this in terms of your running style, or your blood glucose levels, or your alignment to your e-prescriptions and your fulfillment of your hypertensive medicines, or your management of hemophilia, it starts to become a fairly integrated system. And so the Personal Connected Health Alliance was formed. That was followed up by the Integrating Healthcare Enterprises, and that was followed up by two interesting partnerships. The first one in the US called the 21st Century Cures Act, that makes provision for how medical devices can be fast-tracked. Some advocacy groups that don't like that say it means that those medicines or those biotechnologies can get into the market faster than they should. Others are delighted because they say finally we can get properly approved medical devices with appropriate protection. I put in a term there, application program interface, because that's the handshake between all of the different devices. This is the background to how we will progressively and continually manage telemedicine and telehealth going forward. And I suppose at this point, let me just stop there and say the definition of telehealth, and I'm summarizing it, I'm not paraphrasing it, is the use of any and all digital platforms and devices to interface in a way that allows you as a practitioner, to form a diagnostic opinion and provide the appropriate levels of care, directly and indirectly, to your patient. So that's the scope and how broad telehealth is. And that includes mHealth, which is mobile health. It includes eHealth, which is electronic health. And into electronic health, you've got tele-rehabilitation, tele-triage, e-prescriptions, auto-regenerating prescriptions. I work with a through the WHO's medication safety journey in sub-Saharan Africa. And one of the things that they do there is you can go to your post box, which has then a digital attachment to it where you would buy your groceries and have your medicines delivered or receive your medicines there. And the post box switch notifies the pharmacy as to whether you are compliant or non-compliant with your regime. Because if you haven't opened the switch for longer than your prescription is needed to be recharged, you're actually not taking your meds. And then that flags to the practitioner to say, Brad hasn't taken his meds because he hasn't taken the meds out of his box. Now, are you dead? Are you just non-compliant? Or are you taking your meds and selling them to someone else? So this is a lot of where the scope of telehealth sits. Moving forward, I'm going to take you through two summary documents that are contemporary. This is the summary of the American Medical Association Digital Health Review, where they did a survey on their member practitioners in 2016. They redid the survey in 2019, and they published this survey in 2020. So it's about as recent as I could find. And it says 4 key findings that they found. There's an increase of the number of physicians that see digital tools being good, PCPs being primary care practitioners. There are increasingly less people saying that they think it's bad. And the significant issue there is it tends to be older practitioners. If you were born before 1970, you tend to have a less warm view on digital tools and a less strong desire to adopt those tools. The second piece of relevance there is that the use of the tools has grown significantly, regardless of gender, specialty, of age. And when I talk about these 7 tools, I'll share with you this document, but it's really around tools that allow for diagnosis, tools that allow for remote monitoring, tools that enhance telemedicine, are those that are specifically the tools that they're using. These tools, in many cases, are covered by standard medical malpractice, whether you're using a indemnity or whether you're using the cover out of, so indemnity could be insurance cover or it could be cover from a mutual, it doesn't matter. And it also then raises the question, and I didn't put this in because, well, maybe I should have, because it's a book that was released on social media risk, and it says if you don't want naked pictures of yourself on the internet, don't take naked pictures of yourself. I say that because one of the challenges that I have is this thing called WhatsApp. And the reason that's a challenge for me is patients will send me a picture, sometimes an x-ray. I'm the chief medical officer for our Ice Hockey Federation. And I'll get a picture of a partially dislocated acromioclavicular joint or a spiral fracture of the femur or the tibia, fibula, or just a lesion. And people will say, well, what do you think? And the minute you read that, you've entered into a therapeutic relationship. And now that document becomes part of the electronic medical record. The minute it becomes part of the electronic medical record, your liabilities kick in because you're now obligated to respond to that in any way that is clinically or professionally appropriate. So the third piece that comes out from the summary is that televisits and remote monitoring has seen the most adoption. It's still less than 25% of physicians, and I don't know how many of you are in clinical practice and who do this. One of the challenges that we have is in general practice, you can probably get away with doing a video consultation. Obviously, you would need somebody to do the vital signs for you, or have a smart device that does that. But if you are trying to assess the end feel of a joint, the acromioclavicular joint, or you're trying to assess the AC joint to see if there is if the AC ligament is intact or not. The difficulty is you can't do a pivot shift test. You can't feel end feel. You can't test physically and do the exam in the same way. And that's where the telemedicine component came in to say, if you've got somebody doing the test and feeding back to you a clinician assistant, a nurse, you're much more likely to be able to do these more complicated remote visits. Whereas some of the other visits for diseases of lifestyle, diseases of non-communicable diseases, and sometimes communicable diseases are more easily done. So we find that the orthopedic sector, the spinal surgeon sector, the general surgeon sectors are having more difficulty in using these kind of remote tools. That being said, equally, we're starting to see remote surgeries increase. And as remote surgeries increase, it means that in rural areas, if you've got a remote surgical station, the surgeon doesn't have to be there. You need one or two technicians who are in that remote ER. And obviously, you want that ER to be laminar flowed and managed appropriately. But then the surgeon can be anywhere, driving the machinery as if they were doing laparoscopic procedures, robotic procedures. And so I think we're going to see some more of that, but it's going to be interesting to see what the laws do in terms of international liability. And then the awareness of the most emerging technologies, such as what we spoke about earlier, your diagnostic smart tech. So there's watches now that are measuring cardiac arrhythmia and sleep apnea that are linked to SpO2 levels that can generate alerts. There are other smart devices, as you know, that can measure your insulin levels, that can measure the state of your blood sugar, that can generally act like Holters used to act without the medical technology complications, but also allowing us. I remember when we first started looking at SNOMED codes, for me that was in 2004, 2005. I said, imagine if you could have a smart scale that your patient could stand on, and it would link to via Bluetooth to some kind of device that would communicate that to you so that you knew what their weight was and how that weight changed. So giving you some examples of that, you can see the pretty graph at the top. You can see a Gaussian curve, and I remember this from a guy called Everett Rogers back in 1984, who wrote a book called The Fusion of Innovation. This is an innovation curve. And you can see in terms of televisits and virtual visits, there is a significant increase in enthusiasm, relevance, and comfort of using this technology. And it's grown both in primary care specialists, not so much, and probably for the discussions that we mentioned. Younger physicians under the age of 50 are using it more, but we're seeing an increase across the board. The arguments why it's good is it increases patient convenience, you can be more effective, you can provide remote care, you can improve your doctor-patient relationship. And sometimes I wonder about that. Sometimes I wonder if a face-to-face consultation is a hindrance or a benefit. And into that, one of the challenges and one of the benefits of telemedicine is the ability to digitally record and then preserve for prosperity your records. And a question that we would ask from the medical legal side is, why aren't you recording all your consultations? And you don't have to take any documented records. You can record them, you can digitize them. Obviously, you need permission. Interestingly, your patient doesn't need permission from you to record the session, but you need permission from them to record the session. So that is a tool that I think increasingly we'll see is less pen and more digital recording device. So this is the telemedicine. This one is the adoption, and you'll see it's not dissimilar. If you just look up again in the current state, you'll see the technology adoption in televisits is in the early majority, and equally slightly behind that is the remote monitoring for improved care. There is a warmth to this where vital signs, weight, blood pressure, blood glucose, temperature, SpO2 now, can be measured and sent to the office. And the challenge that you would have is how are you integrating that information into your contemporary record? And once you've got that contemporary record, what are you doing to maintain oversight of that patient? Because the difficulty you might have is that the oversight drops. So this was the question that was asked earlier in terms of where in which country is more payment being made. I'm using Portugal as an example is because Portugal was showcased recently in terms of their TENS program, their national strategic healthcare plan. They are very strong in driving telemonitoring, especially in peri-urban and rural, more remote areas. They've got strong self-service appetite where you can, as a patient, request your electronic health record. You can transfer between practitioners the electronic health record content. You can make virtual appointments. You can fill your e-prescriptions. And e-prescriptions we spoke about earlier is a significant and profound part of the conversation. Into that, then, elements of teletriage, telecare, access to health information becomes very much more relevant. And they're driving all of that. They've got their data wallet, which they've called, you'll see it on the left-hand side there, which allows the patient to be able to hold and contain their patient records and then move these records and share these records as they move between practitioners. Back in the day, back in the early 2000s, there was the chairperson of Kaiser Permanente Health System, which was born out of the Californian insurance space. And their system has in many ways been adopted by the German healthcare system, and the SNOMED codes are born out of that journey. And so is some of the FRIH that we spoke about earlier. But their chairperson wrote a book based on his experience with his father, who was elderly and was seeing multiple practitioners. But not every practitioner knew what the other practitioner was doing. And so there was this issue of polypharmia, there was this issue of multiple meds, there was the issue of the antihypertensive meds being diabeticogenic. But the cardiologist wasn't aware that there was an endocrinologist who was treating the father for diabetes because the father wasn't giving a complete diagnosis or a complete disclosure of all of his medicines and his cares. So the data wallet is a very powerful tool to prevent the creation of a polypharmac regime that leads to drug interactivity and the worsening of conditions. In this case, particularly in Portugal, they are paying 10% more on a consultation for teleconsultation than they are for face-to-face consultation. That's different in South Africa at the moment, where the private insurers wanted to pay 35% less. And their argument was, well, you don't have the overhead because you're not in your practice. Because at the moment, South Africa is in a lockdown. And the argument back was, well, it's the same diagnostic opinion. It's the same risk. It's the same quality of decision-making that the clinician needs to do regardless of where they are. And if they don't have to travel and they don't have to lose time, they can see more patients. So this is a showcase. Those of you that are interested after this, I will share all of the reference documents via Keynotion with anyone who's got that request, if that's reasonable. So if we were to carry on from there, this is FHIR, Fast Healthcare Interoperable Resources. And this is what affects our practice, because you've got on where you see X73 smart device, personal health device. You've got all of these devices that include rapid tests, that include tests for insulin levels, glucose levels, respiratory levels, SpO2 levels, temperature, et al. And then you've got all of the behavioral devices that are tracking your weight, your walking, your use of medicines, against your glucose, against your meal plan, against your sleep plan. And then those are being logged in to personal health gateways, PHGs. Now, they're being done in a variety of different ways. And those are listed there, like Bluetooth and across Wi-Fi. But the minute they go across that orange or amber border, the issue of who owns the data comes into play. So if you're recording this data on your patient monitoring devices and they're going into your electronic record is likely to be part of a personal health gateway, and almost certainly likely to be part of a healthcare information system. And if you're in a hospital, you've got a HIMSS to consider as well. The hospital, the healthcare information system and the hospital information management system all interface with each other. So you can see here, if you start using your Strava or your Fitbit or your Garmin or your Apple smartwatch or any of the other, and I apologize for using some brands, but these are the brands that are doing this. And if that information is being consolidated through what they call the data Levantians, including the electronic medical record providers, including Amazon, Microsoft, Google, you will recognize that there is a potential liability for you at each step of where that patient information journeys. It's also very difficult to say, well, how does this information get released? If a patient says, I want my information forgotten, in some cases they can, and you would have to then remove that off your personal storage devices. But there's sometimes, and we're seeing it in relevance now with this viral pandemic, is there are times where public health information supersedes the rights of the individual. And then healthcare can't be forgotten, and the data can't be forgotten. And the GDPR discussion that was had through 2014, all the way through the regulations and the preparation of the e-health guidelines. In the European Union, the e-health guidelines went through three-year journeys from 2012 to 2015 to 2018 to 2021 in the preparation for these kind of interfaces and the architecture that goes with it. So there is complexity to this, and this complexity distracts you from your primary vocation, which is seeing patients. So there's this interesting tension of, I want to see patients, but I need to be more interactive, and I need to have interoperability. And then you also need to have the technology to allow all of these different devices to speak to your electronic record so that you're not missing a key piece of information at any given time. So I hope I'm not scaring anyone out of practice. I did a medical legal talk the other day. Can everyone still hear me okay? Just a thumbs up via.
No. We're doing well. We're doing well.
Okay, good.
No worries.
Well, I worry. It's part of the thing. I did a medical legal talk like this the other day, and one of the ER practitioners came and said he doesn't think he wants to practice anymore. This is too scary. I said, look, it's always been scary. It's just if we're taking the right precautions to manage ourselves. So this is the annual European e-health survey, facilitated by McKinsey & Company. And this was published in November of last year. So it's also contemporary. The interesting thing about this is and this is quite a busy slide, and again, I'll share the presentation with everyone, is that notably what's missing from here is interviews with healthcare practitioners. There are interviews with hospitals and hospital administrators and insurers and consultants and funders, but there's very little data coming in from the people who see patients on a patient site basis. So one of the questions that they do ask, because we can't change that, but they ask the questions, where do we regard the biggest challenges to be? And you'll see legislative issues is always a big challenge. And that also then includes funding issues, because one of the big challenges that we've always had in the EU is who pays. Will the state insurer from country one pay for country two, even though they're in the same EU? And there's been some debates. It actually started with a dental care debate in the Netherlands of patients who came out of the national health system in the UK. And so that was where these debates started. And then that led into large degrees of medical tourism, where patients in one country, let's say Spain, realized that they couldn't get the care at the time they wanted in Spain, but they could get it in Portugal or they could get it in Italy. And so you got this large degree of migration, which then asked the question of how does our data ship between borders, between domestic legislation? So the domestic issues are a big issue. You'll see in almost all of these, interoperability is important. And if not interoperability, sufficiently skilled employees who can do this. Now, it's one thing saying we've got great tools, but it's another thing having the right person to apply those tools in a way that lets work. So you can see here, lack of direction in some. Resistance of staff is very real. I said to you earlier, I've got a colleague who said, you'll have to pry his pen from his cold dead fingers. There's a lot of people who are saying, I hear you, this is wonderful technology, but I'm not using it. And I guess my question to all of you is to ask the question, if you had the funding, which most of the countries do, and most of us have the means to integrate, would we or wouldn't we use the e-health tools to increase telemedicine in our practices? Would we make our practices more virtual? Would we amplify our video and information technology? Would we use our smartphones? And would we use that in a more abstracted way of seeing patients? So this comes out of the e-health study, and it looks specifically at a couple of countries. It looks at the UK. You can see there, their issues are improving data access for clinicians, system usability, and the implementation of electronic medical records are their e-health. When we talk e-health, we're talking telemedicine health or telehealthcare. In Spain, the issues were how to generate and maintain patient-centric data and how to apply the analytics to that data. There are very good tools at the moment from a radiological side that can take the outputs of the scan and use that output of the scan to be able to give you a more reliable and valid diagnosis as to what type of lung-based tumor you may or may not have. But then both in Spain, as you can see there, and in the Nordic regions, there are some issues around IT security. And you see in Germany, they are profoundly aware of IT security. And I'll give you 3 examples of this, just because if I'm going to scare you, I might as well do a really good job. One of the challenges that we had a couple of years ago was of a medical device company that made pacemakers that got hacked. When they got hacked, the serial numbers of the pacemakers got hacked, which allowed people to remotely alter the functioning of the pacemaker. And the question was raised, well, who's liable if the pacemaker identity details, my identity document number, my telephone number, my geography, and my pacemaker serial number is hacked from your system? Are you the person liable? So under the Consumer Protection Act and under the Certain Rights Act, issues around IT security is key, and around how we manage electronic medical records. If you were in practice pre-electronic medical records, how do you convert those records into a digitized system moving forward? So those are challenges to consider. Then we looked and we said, well, what are the top trends coming? And part of that is personal health records and the growth of personal health records. That's a big consideration out of the UK. Out of Spain, artificial intelligence. And artificial intelligence is such a big term, because there's the question of training the algorithm to recognize certain words or phrases or images in order to take unstructured data like handwritten notes or inputs and create structured data that allows them to triage the most likely progression. Now, an example of this that we've all used, and any of you that have worked in emergency medicine, and any of you that have worked with patients who have potential evolving myocardial infarctions or heart attacks, would know that you follow a pathway that was first popularized at Cook County General Hospital in Chicago, written by a Navy physician, Kaplan, who triaged and said, if it's this, then go to high care. If it's this, then go to general ward. And if it's this, then go to ICU. And so using those same decision trees, but on an interfaced, digitized way, allows a lot more data to go through. But the interpretation of that data is only as good as the algorithm, and it can't be relied on. And again, if we use MIs as the example, the presenting feature of crushing pain, anxiety, pain in the chest, pain up the neck, and pain down the arm is fine unless it's abdominal pain without any of the other symptoms, because you do have, as a critical indicator of a myocardial infarction, only abdominal pain. So the AI is only as good as what we train it to do. In Germany and the Nordics, their belief of the top trends is the servicing, and I suppose that's what we're talking about here, the servicing in our practices of telemedicine, of patients using telemedicine. So I think that's where we're going. I don't know how fast we'll get there. And I say that because a lot of the telemedicine ideals that we talk about now were promoted in the early 90s, and they were muted to be out by 93, 94, 95. When I was doing my global health leadership program, we did the health economics in Barcelona at Pampa Fabra University. And at that stage, the question was, it's not if there's a respiratory illness that mimics SARS that's highly contagious, it's when. That was 2005. And at 15 years from there, where we are now, but we are not really significantly yet adopting telemedicine in the manner that was predicted. So that brings me to the discussion time, because I promised that there would be time for questions and discussion, and that's what I like to leave here. So let me pause at this point and say, what questions or challenges would you like to talk about? Would you like to talk about the practical implications? Would you like to ask specific questions? I'm opening it up to the broader audience, Ariane.
So, don't be shy, ladies and gentlemen. I'm gonna unmute everybody. So if you would like to speak, or if you're a little shy, write in your questions, type in your questions on either the chat box or the Q&A. And if you would like to speak, do raise your hand, and I'm gonna start keeping a lookout. Meanwhile, thank you for the very impressive presentation, Brad. If I may ask, like, if there's one takeaway from this presentation, what is that takeaway for the audience?
I think that's a fair question. And I ask that as I sit and I look at my practice on a daily basis. And I think it's this, is how do we start better using the digital technologies to assist us with patient care? I think there are very good technologies. I think there are also overwhelming technologies and a huge amount of them. But what is the first next step? And for me, and I suppose it's a challenge, because my challenge is, can you use technology in the first next step to take better patient notes? Because better patient notes affords three things. It means a more thorough questioning session. It means a more thorough reflective session from the patient. And it means a vastly improved ability to follow up when one does referrals to colleagues.
Okay, yeah, let me pick one participant to get him to talk. Hi, Anders. Thank you for joining us in today's session. If I may ask you a question, what are your challenges, and how can today's session help you in your job? Anders?
Well, let me say this then, as we go through. I think a key point here is, and I bring up this slide maybe as a way of closing. There were 7 specific components that we looked at globally, and we continue to look at. Hospitals look at it, medical insurers and payers look at it, and I suppose to some extent the colleges look at it. And the first is, can we use remote monitoring for efficiency? Is there efficacy to getting people to do a lot of this work themselves? Taking temperatures, taking blood pressures, doing blood glucose levels for our chronic patients with non-communicable diseases. And if we do that, are we then able to ensure better compliance with them, for them, and partnering up then with the various pharmaceutical providers? Because I think if we get that right, and we're better able to manage our non-communicable diseases, we can prevent unnecessary severity in terms of what they call QALYs and DALYs, the quality adjusted life year and disability adjusted life year, by minimizing the amount of comorbidities that our colleagues face and our patients face. I have a question that says, how can we motivate medical practitioners and patients to use health apps to support communication and exchange of data or monitoring health data? So I'm going to answer that live and say, I do not know. And part of that is by getting, like what Portugal's done, significant incentives for people to do it. But part of it is also to create within your clinical network a group of clinicians who are willing to participate. Because once you've got a clinical group who are routinely sharing information on the same or similar app, or apps that are supportive of each other, that network becomes quite structured. And then each person in that network increases that. So if you've got, and I refer you as an example to a book written by Malcolm Gladwell called The Tipping Point. You've got mavens who are thought leaders or peer leaders. And I think if you can find in your community key clinicians and practitioners with key patients who are willing to do that, you will progressively get an increase in the use of these apps. That's how we've seen it grow. We see it grow by a community using it, and through the adoption by that community and the support of a website or of a social media site, that grows. We've seen that in Alzheimer's support groups, we've seen it in diabetes support groups, in asthma support groups, chronic fatigue support groups. We also see it via funders. So the health insurer says, quite happy to pay you, and I'll pay you more if you do a discharge summary that's electronic. So there's the financial and there's the social imperative to allow that. So good luck with that, and if I can help, let me know. We've been trying to do peer incentivized performance and participation since the early 2000s, and the hardest thing to do is change someone's habits. But there's a slide I used. I spoke in Barcelona. I must say it was very disappointing being in Barcelona in October, because all I wanted to do was go to Paleta de Música and listen to one of my favorite performers. And that was the time where, for good political reasons or bad political reasons, depending on your affiliation, Barcelona was very unsettled. But what I did there is I put up a slide, and I don't have it to show you here. What that slide showed is it says, who wants medication? There was a long line, and next to that it said, who wants lifestyle changes? And there was no one there. So it's much easier for people to get medicines than it is to change lifestyle and exercise. But I think at this point we probably need to stop, because we're at the hour. To Keynotion, thank you very much, and to all of you who tuned in to listen, thank you very much. You do have a mechanism to contact me if you need to. Those numbers are on the screen. And again, thank you very much.
Well, thank you very much, Brad, for the very comprehensive and I must say very impressive presentation. And this is not only Brad's time with us today. He's going to join Keynotion again on 19th of May. Put it down on your calendar. We're going to also send you more information as well. I believe that it's also related to what the topic today, and the topic will be R&D and intellectual property. So, so do to also tune in on the 19th of May if you would like to have more questions for Brad as well. And I believe we could also take it on next week, right, Brad?
Correct.
Okay, so we'll see everyone, and definitely looking forward to have you with us again next week, and have a great weekend, everyone. Bye.